I want to start today by giving you a schedule reminder that next week we have exam 1. So today's the 23rd, and then next Tuesday's class, January 30th, will be the first test of the semester. And it'll be on muscle relaxants, of course. That's what we're studying. And the reading assignment is chapter 12 in the book. That's a chapter on muscle relaxants, which contains all the material that I'm covering in class, the last 3 classes. And at the end of class today, I'll go through what I'm going to ask you. So that's for next week. So the next time we will meet will be Tuesday, February 6th for class. It's 2 weeks from today. And that's it. For those of you here in this room, you want to come in at 8 instead of 7?
Yes.
It's not going to take 3 hours to take a test. So how about we start at 8?
What'd you do?
You can go more try.
Yes, please, this will mute it. But if I knew where the...
I didn't want to be that.
Oh, it's a
You can be that.
Okay.
Let's get up the stair.
Jim, let's. Class in bed. All right. The last week we went through succinylcholine and started on the non-depolarizers. We'll of course finish it all today, so we can have a test next week, and then we'll start with local anesthetics. But in order to backtrack a little bit to what we did last week, let's turn to page 31. Page 31. Okay, we started out with succinylcholine, and then of course mentioned that it was just acetylcholine, 2 molecules stuck together. Metabolism is on the next page, 32. It's metabolized by, of course, cholinesterase. The 2-step process to succinylmonocholine and then succinic acid and choline. The choline is taken back into the nerve. Used choline acetylase as the synthesizing enzyme for acetylcholine, and that makes new acetylcholine, and the succinic acid goes off to the Krebs cycle. On the page 33, I went through the hydrolytic enzymes, starting with cholinesterase, and there's a zillion different names people have come up with to talk about the different isoenzymes of cholinesterase. This is from the American Society of Pathologists, who actually are the group that names these things. And basically they break it down into 2 types. Acetylcholinesterase, which is in the synapse of neuromuscular junction, and pseudocholinesterase, which is in the plasma. Agents that are not broken down by cholinesterase and are referred to as being broken down by non-specific esterases, and that's at the bottom of page 33. So cholinesterase, acetyl and pseudo, and the non-specific esterases, RBC, peroxidase, and albumin esterase. And then 34, I listed some of the drugs that are broken down by each of those groups of enzymes. On the bottom of page 34, we went through that. Then on 35, we talked about atypical pseudocholinesterase, and that is that there are certain subtypes of the enzyme that various ethnic groups will have, and it's perfectly normal for them, but it may not catalyze the hydrolysis of choline drugs, choline esters, as we normally think they would. And the most common atypical enzymes are E sub A, which is classic atypical, There's also fluoride in salmon. Just ran out of batteries. What's that? What's that? Okay. That's better. So we talked about atypical and the various forms and so on. Then on page 36, there's the diabetic inhibition test and the potential results and what they mean. I won't beat that to death again. 37 went through the side effects of SUCs, and most importantly, because I'm going to ask you this on the test next week, what are the contraindications to use the SUCs, and that's page 38, spilling over onto page 39. So obviously you need to know who not to give succinylcholine to. It's pretty standard stuff. Then page 41, we started with the non-depolarizers, the benzoyl-isoquinoline or curium drugs, atracurium, cisatracurium, and mivacurium. And then the steroidal relaxants on page 43, the omium drugs, pancuronium, vecuronium, and the ever popular rocuronium. Page 44, yes, this I'm going to ask you on the test. How is each of these drugs metabolized or eliminated from the body? In what manner? So you know that if a patient has certain difficulties, say renal problems, don't give them a long-acting drug that has renal elimination. If they have liver problems, etc., you know the drill. So that's page 44. Then summarize it again on page 45. Now we finished up on talking about the dosing, and so let's go to page 54. And I finished up last week by talking about this table, which is Dr. Miller's book's table, on the different relaxants. And I try to simplify it a little bit with the following. The ED95 of the drugs on the next page, my version, are listed. And the dose for intubation is 3 times the ED95. So whatever the ED95 is, just times 3 it if you're going to use it for intubation. And the fact that the anesthetic gases, Hevodiaz and isoflurane, will have an additive effect on the relaxant. So when you're reversing somebody at the end, you have to decrease your gas before they'll be able to get full recovery. That's kind of where we left off last week. If you look on the next page then, I've tried to make it a little easier to summarize it with the following. So this is page 55. Page 55. All right, the ED95 of SUCs is about 0.5 to 0.6. The inhibiting dose, as I mentioned, is about 1.5 times milligrams per kilo, or that rounds off and an average 70 kilo person do about 100 milligrams. And basically you can give 100 milligrams to just about anybody. Because it's so they're all totally water soluble, their dosing doesn't vary as much with weight as some other drugs do, because they stay in the body of water. So just give 100 milligrams and you'll get any adult paralyzed. Mivacurium, the ED95 is 0.08. Atracurium, we don't use really. Cisatracurium is 0.05. You notice vecuronium and pancuronium are also 0.05. So all those three are the same. And rocuronium, I think you know the dosing since you give it to every patient every day, all the time. and that is 0.3 milligrams per kilo. Intubating dose is about 1 milligram per kilo, 3 times 3.3. And that's it. So, if you look at time to onset, of course, sucks is 30 to 60 seconds. And the beauty of sucks, as I mentioned last week, and you'll soon learn this when you give it enough, is that it's pretty absolute. About 30 to 60 seconds, it'll paralyze anybody. There's not a lot of variation with its effect. The rocuronium C is the fastest non-depolarizer. That's listed at 1 minute to 1.5 minutes. That's at the intubating dose of 1 milligram per kilo. So it takes a little bit longer for rocuronium to work versus succinylcholine, but it's certainly within a reasonable time frame if you're doing a rapid sequence induction. Okay, anybody have any questions about any of that? Now on the bottom I mentioned 2 things. I'll just say them, but I'm not going to ask you this. Just say what they are. Something called the priming technique and the timing technique. All right, the priming technique is this. People thought, and rightfully so, that if you can give some of the relaxant before the patient goes to sleep, get it in early, then when you give the rest, you'll get more faster effect. So in other words, prime the patient's system. Give some first, then put the patient to sleep and give the rest. You'll already have that some in there working, and it'll work faster. The downside of it is what? If you're giving someone a relaxant when they're awake, you don't want to paralyze them when they're awake, right? That's the downside. So there's a limit to how much you can give early, and normally they say around 10% is a priming dose. So let's calculate. Let's say that I'm going to intubate somebody with rocuronium. I'm going to give 1 milligram per kilo. The patient weighs 60 kilos. So I'm going to give 60 milligrams of rock. So I'll give 10% of that, 6, 8, maybe even up to 10 milligrams ahead of time. Give it, wait about 30 seconds, hit the patient with propofol, knock them out, give the rest of the drug. And that would make the onset be a little bit faster than if you didn't do that. That's the idea behind the priming technique. And I know that some of you may work with people that do that, and that's fine. I mean, whatever works for you. If they're good at it and they like it, that's good. Like I said, the downside is you may have patients who get some weakness because you are giving them a decent dose of relaxant while they're awake. So you'll see that sometimes they can't blink their eyes, or they'll feel a little heavy, feel a little funny. But if you hurry up and give the propofol, they won't remember anyway. So that's the idea behind that. And the timing technique is similar. This is you give all the relaxant while the patient's awake. So get everything ready to go, and then say you're going to do that same patient 16 milligrams of rocuronium. So you put the syringe in your little stopcock or whatever, and you give 60 milligrams of rocuronium to the awake patient. Right? It takes a little nerve to do that. Then immediately, I'm talking about 1 second later, you hurry up and give the propofol, assuming the propofol is going to hit before the rocuronium does. That's called timing. You're timing the relaxant first before the propofol. And some people do that as a way to make it work faster. I'm not sure I'd be gutsy enough to do that. I don't want to paralyze somebody away. Now my solution, I've talked about it before, and many other people do the same thing. In fact, anybody who's rational does the same thing. And that is, if you're doing a rapid sequence induction, then whatever technique you pick, just ventilate the patient while you're waiting for the relaxant to work. Give small, little slow respirations. You're not going to hurt the patient. Let them breathe. Don't keep napping for 60 seconds or 75 seconds. Then go intubate. Give them some small breaths. You're not going to make them throw up or anything like that. And take the drama out of it all. Okay. All right, makes sense? Any questions? Let's go to page 57. Let's talk about reversing. Sorry, so let me talk about reversing, and then we'll get into all this gory detail. So, of course, I've mentioned several times, you understand this already, having given anesthesia, even for a short period of time, that the end of the case, you have to get rid of the relaxant. 100% rid of it. So the patient has their muscle strength, so they can recover properly and breathe and all the rest of it. Have their reflexes, so they can potentially protect against aspiration, etc. And so the question is, how to get the patients 100% recovered from the relaxant. The best way. What are the signs to look for, and so on. Well, there's a lot of push right now. In fact, there's almost a whole journal dedicated to it a couple months ago, and trying to get people to use quantitative monitoring to determine how paralyzed somebody is before you go to reverse them. In other words, you want to use accelerometry, and it's a special monitor where you put a little thick clip on the patient's thumb and watch thumb movement, and that can calculate, the machine will tell you, spit out a train to 4 ratio and how paralyzed the patient is and so on. And it's not subjective, us eyeballing it, but rather it's objective, and the machine will calculate a percent paralysis. Nobody wants to do that. So all the leadership in the anesthesia world are promoting this. Oh my God, you can't even give anesthesia without it. Otherwise, how do you know how the patient's paralyzed and when you're going to reverse, and yada yada. And we can't even get people to use qualitative measures, little nerve stimulators. So, that just make you aware of the current, push in the academic world versus the real world, clinically. And most anesthesia providers, both docs and CRNAs, feel that residual paralysis, in other words, not having patients adequately reversed, is not a problem in their practice. They do surveys, I quote some in here in this book, and you can look at them, where they say, well, how often does residual paralysis come into play in your practice? 1%, 2% of the time. Once in a while I'll see it, but I recognize it right away or whatever. So that people feel like us that work daily in the OR, that it's not a problem. But then they'll do studies and they'll have some objective observer measure the patient when they get to PACU, see if they're still paralyzed, and 30% are still paralyzed, have some residual paralysis, 35%. Why is this big discrepancy between what we see, or think we see, and what the researchers calculate out? Most likely it is because most patients are healthy, and even if they have a little bit of residual weakness, they can breathe anyway, and then it kind of wears off after 15, 20 minutes in the recovery room, and it's not really a clinical issue. It becomes a clinical issue in people who have multiple organ failure, sick, ASA3, ASA4, that kind of patient. They have major surgery, and maybe more of an issue. So there's a big discrepancy between what we think we see and what the academics tell us we're not seeing. And so there's a real push to get us to use quantitative measuring. But there's also many clinical signs, and that's what this page 57 talks about. And a lot of people feel that now with the introduction to Ciabadex, that's going to take a lot of the worry out of it. If you just reverse them with Ciabadex, it's fairly absolute, assuming you're using rocuronium. So we'll talk about that in a minute. So anyways, let's look at some clinical signs of recovery. When you get to the end of the case, you want to see as many of these as possible. Some you can see in the OR, some you can see in the recovery room, some you aren't going to see in this particular patient, whatever. All right, let's take a look at it. So on top of page 57, common clinical signs of recovery from neuromuscular blockers. Obviously, first you got to be breathing properly. Adequate tidal volume and rate. Nice and smooth, not labored. Easy respirations, nice tidal volume, nice rate. Respiration smooth and unlabored. The patient can open their eyes widely on command. No double vision. Why is that important? Well, the eye muscles are the easiest to paralyze, So if the patient can open their eyes and look around and so on, chances are they're not very paralyzed because their eyes are back. Sustained protrusion and purposeful movement of the tongue. If they can control their tongue, stick your tongue out, patient sticks their tongue out, they have strength enough to do that, then they can handle most likely their airway. When they fall asleep, the tongue's not going to fall back and obstruct them because they have tongue strength back. Effective swallowing and sustained bite. Of course, swallowing, retching, and vomiting reflexes go out together. So if you can swallow, chances are you have your retching and vomiting reflexes. Remember signs and stages of anesthesia last semester, September, seems so long ago. But those reflexes come and go together. So if the patient's swallowing, and you see this almost every case, at the end of the case, if you let the patient start waking up from the gas, you'll notice, even if they have a tube in or LMA in, that they start to swallow. That's a good thing. I'm glad I see the patient swallowing. It means they're reacting to the airway. They're light enough to get the reflexes back, and enough relaxant's gone to let the reflexes back, and that's a good sign. Able to sustain a head lift or leg lift at least for 5 seconds. In small children where you can't get them to do what you tell them to do, if they can bring their knees up to their chest, which they commonly will do spontaneously, that's a good sign they have leg strength in reversal. So raising your head off the bed for 5 seconds is a good sign that they have some consciousness, they can respond, and they have muscle strength enough to do that. Arm lift, touch the opposite shoulder. So, can you touch your nose? Can you reach over there and touch your shoulder? That's a good sign. Strong, constant hand grip. Squeeze my hand. How does it feel? Does it feel strong? Do they squeeze and then immediately let go because they're too weak to sustain it? That kind of thing. Can they cough? That's a good sign. If something gets in their airway, they can cough it out. We hope will happen when they recover. A good vital capacity, a good inspiratory force. That is, can they breathe strongly in? Can they suck a good breath in? Sustained tetanus at 50 hertz for 5 seconds. No train of 4 fade. 0.9 recovery. And no fade to DBS. So those are all kind of signs of recovery that you're looking for in every patient as the patient gets better. But what happens if they have some residual neuromuscular block? And I told you this story before, and it's okay to mention it again, I guess, is when I trained, we used to consider reversing we had neostigmine in those days. We used to think reversing with neostigmine was a failure. That meant that you weren't titrating the relaxant the right way. Because similar to the way we think about narcotics nowadays. We like to give narcotics and not have to reverse with Narcan, leave some residual around. Well, we used to think that we used curare. When we gave curare, the patient, the surgeon was ready to close. It would take an hour 15 minutes, as I mentioned before, for them to close. And so in the meantime, we could just let the curare wear off. They got them back breathing, and when the case was over, they were breathing nicely. We'd pull the tube, we'd take the patient to the recovery room. They were still 60% paralyzed. They got tired and they ended up having a code in the recovery room, or at least anesthesia staff to come back in and intubate because the patient wasn't breathing properly. So we coined the term recurrization. We said the patient got recurrized. Well, they didn't get recurrized, they just never got decurrized. They were still paralyzed and we weren't smart enough to recognize that. So my question here on the previous page, is there such a thing as recurrization? My answer would be no. What it is the patient is not adequately reversed in the first place. So they didn't go back to paralyzed. They just never got properly reversed. So what happens if they do have some residual neuromuscular block? Well, in volunteer studies on page 58, in volunteer studies, you get impairment of the pharyngeal coordination. Somebody's not muted, and think it's, I can't tell. Oh, thanks. That did it. Impairment of the pharyngeal coordination. So this is a biggie. They put it first. And the reason is this. They used to say, well, the train to far ratio returns to 0.7. That's considered normal. Then they found out that one of the last things that you recover from wearing off a relaxant is your strength in your pharyngeal, oropharyngeal muscles. So you still had weakness in there, which meant if you vomited, you had a possibility of aspirating. If your neck muscles, your oropharyngeal muscles are weak. So notice in the first thing on page 58 there, impairment of pharyngeal coordination. It takes at least 90% recovery of the train of 4 before you can see full swallowing and retching and vomiting and all the rest of that strength. Swallowing dysfunction, delayed initiation of the swallowing reflex, increased risk of aspiration, airway obstruction, and if you look at these under clinical studies in actual surgical patients is the second thing, increased risk of post-op anoxia, airway obstruction, delays in discharge, etc. Just what you'd expect. The two things you worry about. I said this last semester, I've said it a million times, I'll say it again. When you're going to pull a tube out of somebody, you have to answer two questions to yourself and your brain. Number one, when I pull this tube out, can the patient breathe? Number two, when I pull this tube out, if the patient vomits, are they going to aspirate? If you can't answer yes, they're okay on both of those measures, then leave the tube in. You got to be guaranteed that they're, number one, they're going to breathe, and number two, they're not going to be susceptible to aspiration if they in fact do have some stuff in the back of the throat or they vomit or whatever. You notice all these adverse effects of residual block all have to do with those two things. You can't swallow, you can't prevent yourself from aspirating, you get obstructed, you get anoxic, you know the drill. You got to make sure the patient's got adequate strength back. Now, what are some of the factors? This is page 59. These are factors that can influence whether you end up with residual paralysis. Well, first of all, the definition of residual paralysis they're mentioning here. And if you do train of 4, objective monitoring, if the train of 4 ratio is less than 0.9, if the fourth twitch is less than 90% of the size of the first twitch, that's what that means. If the train of 4 ratio is less than 90%, the patient's still paralyzed. Or if they have clinical signs or symptoms of muscle weakness, then that's obviously also a sign of paralysis. And if you've seen a patient partially paralyzed when they're waking up, trying to move and they're breathing, and their stomach sticks out and in, and they're breathing uncoordinated, their arms and legs are kind of flapping, they say it's like a fish out of water. You lay it on the dock and you see her fishing, you see the fish flapping around. That's what a person, their arms and legs are flapping around, the stomach is moving, there's nothing's coordinated, and it's one of those things when you see it once, you'll see it, you know it for the rest of your life. What somebody looks like when they're partially paralyzed, trying to wake up. Number 2, type and dose of the relaxant. I mean, obviously, if what relaxant you use matters, and how much you gave matters, and so on. Intermediate versus long, we don't use long-acting anymore, because you can't reverse them as well. Using neuromuscular monitoring to administer the drug, qualitative, quantitative, etc. The degree of neuromuscular blockade maintained intraoperatively. You want to keep the patient at 1 or 2 twitches, which is adequate for most procedures, and were you able to do that? What anesthetic did you give along with it? Did you give gas? You're going to have to get rid of the gas. Are you giving stigmine or adifonium? We'll talk more about those in a minute. And then how long does the case last? A longer case, more sophisticated surgery, more invasive surgery, obviously it's going to be a little bit more difficult to reverse the patient. So how long has it been since you reversed, and so on. And is there any patient factors around that might influence? They have metabolic derangements, acidotic, hypercarbic. Are they cold? You can't reverse people who are cold very well. So is there any drug therapy that may be causing an interaction? Are they getting opiates? Are they getting antibiotics? And all the things we talked about. So this is kind of common sense reasons why you might not see a patient reverse properly. On the next page, I'm repeating myself because that's what I do. Factors influence the incidence of residual plaque. And again, I think you could probably give me all these. Pre-op factors, how you're defining it. Does the patient have any muscle weakness or patient factors? Are they old and beat up? Pre-existing medical conditions or conditions known to affect neuromuscular transmission, and anti-seizure drugs which can cause muscle relaxation, etc. Interoperatively, what type of relaxant you give, how much you gave, when was the last dose, did you monitor or not, did you keep them deep or lighter, did you use gas, and then factors related to the antagonism, what reversal agents did you use, how much did you give and when did you give it, etc. Factors, next page, factors related to the measurement of the blockade, what type of tests are you using to measure, and does the patient have any metabolic issues that make it difficult to do this? So that's kind of common sense stuff. All right, the next page, 62, and then I'll stop doing it, I promise. But I wrote these up. What do you do when the patient is not reversing properly? Considerations when return of muscle function is incomplete. This is going to happen to everybody. Very common. Unfortunately, what happened? Okay. Bullet number 1 on page 62. As with any reversal agent, the ability to counteract a non-depolarizing block depends on the amount of spontaneous recovery before the administration of the reversal drug. The patient has no twitches, they're 100% blocked, and you go to reverse them, it's going to be harder than if they're already 4 twitches, but small or whatever. But they're getting some recovery, obviously. It's easy to reverse that patient than it is somebody who's highly blocked. That's common sense. Has enough time been allowed for the anticholinesterase to antagonize the block? Sometimes it can take up to 15 minutes before you get a decent response. So Gammadex, of course, is much quicker, and we'll talk about that in a minute. Is the neuromuscular block too intense to be antagonized? Maybe they're 100% paralyzed plus. They've got another 20-30% on board. Maybe their post-tendon count is very low, 1 or 2. It's going to be hard to reverse that patient, just put them on a ventilator. Even if recovery appears clinically adequate, a small dose of neostigmine may be prudent if the time since the relaxant administration is less than 4 hours. Here comes a common clinical question. You may have had it yourself. You give somebody a relaxant, and then you don't need it anymore. Say, sometimes in orthopedic cases, or you only hip or some other procedure, need the patient paralyzed to get in to the operative area, but after that they don't really need paralysis, so you just didn't give any more. The case lasts 5 or 6 hours. You haven't given any relaxant in 5 or 6 hours. You're sure the patient's reversed. Should you give reversal at the end? And this data shows, even if recovery appears adequate, if it's been less than 4 hours since your last dose of relaxant, give a little dose of neostigmine anyway. You can still have residual paralysis. So 4 hours is the big cutoff point. If you got a 10-hour case and you haven't given any relaxant in the last 8 hours, I wouldn't worry about reversing. But if it's less than 4 hours, the academic data shows you might have a little bit of residual paralysis. Has metabolism or are other anesthetics or adjuvant agents contributing to patient weakness? Right? Did they get antibiotics? Did they get gas anesthesia that you got to blow off, etc.? Has the metabolism or excretion of the relaxant been reduced by some unknown process? The patient maybe had kidney disease. They have liver disease, and you didn't take that into consideration. And now it's lasting too long or whatever. They have acid-base, electrolyte problems, temperature, age, drug interactions, or any other of those factors that might come into play for why they're not reversing. And of course, lastly then, the safest approach when any question as to successful reversal remains is to keep the patient airway controlled, intubated, whatever, put them on a ventilator, sedate them so they're not awake, let everything wear off. It'll always fix the problem, always. No matter what the actual issue is, you've always got a safe pathway to recovery in that just ventilating the patient until they can regain their strength. And sometimes it's hard to do that. Oh, the patient only had a little lumps and bumps surgery and I'm taking her to recover with a tube in. The nurse is going to look at you like, oh, why is this patient intubated? Well, sometimes they just don't reverse right. You have to bite the bullet, make the call, and just do it. It'll work out in the end. Okay? Now, let's take a look at the next page, 63, and talk a little bit about reversing. I listed the reversal drugs. There's neostigmine, edrophonium, which is tensilin, of course atropine and glycopyrrolate, and the great big drug of the moment, Sugammadex. So let's stop for a minute and talk about neostigmine. If you go to the next page, you're going to see a drawing, and I'm going to go on the camera point. Thanks. I look. All right, this is, let's read what the guy says here. Enhancement of endogenous ACH action results from increasing release, and this is how acetylcholine is broken down, or how neostigmine works. So take a look at this top set of panels here. This is normal. So this is physiology without any drugs. Acetylcholine is released. It is acted upon by cholinesterase. The choline is broken off. Then the succinic acid, acetate goes off. And the choline is used to make new acetylcholine, and that's it. So cholinesterase is breaking down acetylcholine. Right? It's not a big mystery. We all know that, right? All right, the second panel. Neostigmine is given. Goes into the neuromuscular junction. It attaches to cholinesterase, that's this blob here. And it takes a while, but sooner or later, one part of the neostigmine is released, then the second part is released, and the acetylcholine goes back to normal, ready to do the next molecule. But this process takes from neostigmine being given to being metabolized by cholinesterase. It'll take around 45 minutes to an hour. So how does neostigmine work? Well, we all know, we learned this last semester, it's an anticholinesterase drug. But what it does is it's, in pharmacology, the term that's used for this is called an alternative substrate. You give a drug that acts as an alternative to acetylcholine. So in other words, cholinesterase is sitting there in the neuromuscular junction waiting to metabolize acetylcholine. Instead, you give it neostigmine. It goes in the neuromuscular junction and it acts as an alternative to acetylcholine. So then the cholinesterase is busy breaking the neostigmine down, takes 45 minutes instead of milliseconds for acetylcholine. And while it's busy breaking down neostigmine, acetylcholine esterase cannot break down acetylcholine. You can only do one thing at a time. So acetylcholine levels then build up. That's what they're showing here. And you end up with high level of acetylcholine in the synapse. When the level of acetylcholine exceeds the level of the relaxant, then by the law of mass action, probability of the acetylcholine, going back to normal physiology, is higher than the probability of the relaxant being on the receptor. So we give neostigmine, we purposely inhibit the breakdown of acetylcholine by doing that. That's the whole point. Acetylcholine builds up, and when the amount of molecules of acetylcholine is greater than the amount of molecules of relaxant sitting outside the receptor, then the probability that acetylcholine is going to be on the receptor is higher than that of the relaxant, and the patient's reversed. Does that make sense? Now, that's all fine and dandy in the neuromuscular junction, but neostigmine is given systemically. You give it IV to the whole body. And it's also building up acetylcholine in the muscarinic acetylcholine sites, parasympathetic nervous system. Because it's building up acetylcholine in the parasympathetic system, you can get a vagal or parasympathomimetic effect from neostigmine. As a matter of fact, you will get, guaranteed, 100% of the time, a vagal effect if you don't co-administer some Robenol or some atropine along with it, most of the time Robenol. Robenol then protects the muscarinic receptors, it's anti-muscarinic, without affecting the nicotinic neuromuscular junction receptors, so you can reverse the relaxant in the muscle and without having it cause problems in the muscarinic sites. What kind of things would happen if you just gave neostigmine without the Robenol with it? Bradycardia, bronchoconstriction, having problem breathing, a tremendous increase in GI motility, you get it with diarrhea, GI cramps, etc. All things that don't sound like you want them. It's not what you want to do for the patient. So we give Robenol to protect the muscarinic sites while the neostigmine is reversing the relaxant at the nicotinic sites. Does that make sense? Is everybody kind of with me on that? Good. Now, neostigmine, therefore, is kind of an indirect reversal agent. It's not like Narcan reversing a mu receptor full of morphine, or it's not like Cigamedex binding relaxant. Neostigmine works indirectly because it builds up acetylcholine, and the acetylcholine then reverses the relaxant. The less relaxant that is there, the easier, more likely, the neostigmine is to work. So that's pretty straightforward, right? Now, look at the bottom of page 63. Reversal maximum doses. And I put there for neostigmine and edifonium, I put neostigmine 5 milligrams, edifonium 1 milligram. Here's what I mean by that. Look at the dose of neostigmine on the top. Dosage range, 25 to 75 mics per kilo. So if we take the 75 mics per kilo in a 70 kilo person, multiply it out and round it off, it's going to be what? 5 milligrams. So that's the top dose of neostigmine, 75 mics per kilo in a 70 kilo patient, round it off, smoothed out, it's about 5 milligrams in an adult. Now, if you give 5 milligrams of neostigmine, you get 100% inhibition of cholinesterase. 100%. So in other words, that's the maximum effect you can get. You can't inhibit the enzyme any more than 100%. So why don't you give 9 milligrams of neostigmine, 10 milligrams of neostigmine? If you can't reverse them well, just give more, right? That's kind of a logical pharmacological story. And the answer is because you've already got 100% inhibition. So giving more isn't going to get you any better effect. In fact, if you give more, then you can start to get some weird stuff in the neuromuscular junction. Neostigmine itself in high doses can cause relaxation. There's some problems with that and so on and so forth. So that's why we say there's a maximum or ceiling dose for neostigmine at about 75 mics per kilo, because what's the point? If you give 75 mics per kilo of neostigmine and the patient doesn't reverse properly, they still have residual paralysis. It's not the cholinesterase that's your issue. There's something else going on. And giving more neostigmine isn't going to fix that. Maybe they got an antibiotic interaction. Maybe they got acidosis. Maybe they're cold. Maybe they still have too much gas on board. I could go on like this for half an hour telling you maybe. But the answer is, don't give any more neostigmine. You're just going to make problems for yourself. You've already maximum reversed them. Now, the new twist to all this is, of course, the introduction of Sugammadex. And the question then, if neostigmine didn't work, can you give Sugammadex? The answer apparently is yes. You could always switch to that. But nonetheless, I think you're better off just letting the patient ventilate and let it wear off on its own. That's another story. So, here's the reversal. Say the dose is 25 to 75 mics per kilo. So let's take a 25 mics per kilo dose. That would be around 2.5 milligrams. That would be kind of a half maximum dose. That's a good starting point. Here's what's going to happen when you work with people in the OR. You can see all these different permutations, and they all work. Right? Some people give Robenal first, all by itself. They wait to get a little bit of tachycardia so they know it kicked in. After 1 or 2 minutes, I'm sure it's working. Then they'll give neostigmine the reverse afterwards in separate syringes. That works. Good for them. Here's another way to do it. Put the Robenal and neostigmine in the same syringe and inject it that way. So you're giving your 2 or 3 milligrams of neostigmine with 0.8 or a milligram of Robenal, and the same syringe. People say that because the neostigmine is indirect acting, it takes a while for it to build up acetylcholine. The onset's going to be at least 5 minutes. The Robenal is going to work faster. Just give them together, and the Robenal always works first anyways. So save yourself a syringe. Save yourself trouble. A lot of people do it that way. In fact, I think it's probably the most common way. Is people put them together. Secondly, if the patient doesn't reverse adequately, then people will go ahead and give another dose up to a maximum of 5. So say you started with 2 milligrams of neostigmine, you're not happy with the result, the patient's showing some weakness, he's not coming back quick enough, go ahead and give another 3, up to 5 milligrams total. So you reverse them twice. Smaller dose first, then a second dose. Here's what other people do. They give 5 milligrams to everybody. Figure, oh well, let's just go for it. 5 milligrams. So the maximum, they just give the maximum. Well, that's fine too. That works. Some people will look to see where they start, or when they start reversing. You've already got 4 twitches back. Obviously the patient's got some decent recovery. Then just give them half a dose of neostigmine, like 2.5 milligrams, 3 milligrams. If they don't have any twitches back, or barely 1, then go ahead and give them 5, because you know that they're pretty paralyzed. You can adjust it according to the patient's response. You know how much relaxin they've gotten. You know which one you gave. You know when the last dose was given. You know how the patient's been responding. Did you give a little bit of rocuronium? The patients didn't twitch for an hour. That's somebody that's pretty sensitive to relaxin. I'd go ahead and give more neostigmine than that. If you gave a relaxing dose of neostigmine, rocuronium, and 20 minutes later they're already moving, twitch, they're kind of heating it up, they're taking a lot of higher dose, then you wouldn't have to worry so much, they're wearing it off faster. So you can go by the experience of the case and adjust it accordingly. All those different ways work, they all work. The point is, don't give any more than 5 milligrams of histamine, because at that point, you're just going to cause yourself more troubles. If it didn't reverse, you have to figure out some other reason. Treatment will always be the same. Now, edrophonium is another anticholinesterase, and it's short-acting, rapid-acting. So here's what I'm going to ask you in the test next week. Which one works faster and is shorter acting? Edrophonium. Which one is slower onset but longer duration? Neostigmine. That was easy. Now, edrophonium people give when they want the patient to reverse quickly. That was the tradition. So let's say you got 3 or 4 twitches back, but you want to make some reversal, but you're in a hurry. They use edrophonium, and because it works faster than neostigmine. The problem is edrophonium has a lower efficacy. It doesn't work real well if the patient's really blocked, 100% blocked. Wouldn't want to use edrophonium in a very blocked patient. It only works well in patients who are recovering pretty much on the ground, starting to. Secondly, edrophonium is always mixed with atropine, or it's given with atropine first. The reason is atropine is a faster onset than Robenal. Edrophonium has a fast onset. So you want to mix the 2 fast onset drugs together. If you mixed edrophonium and Robenal, maybe the edrophonium would work first. You wouldn't want that to happen. See what I'm saying? The company, in fact, that makes edrophonium even markets it with the atropine already in it. Because they know everybody just uses atropine, I'll just make it convenient and just put the atropine in there for you. The normal dose, as you can see, is 500 to 1,000 mics. That means 0.5 milligram to 1 milligram. If you're going to reverse somebody with edrophonium, you start with 0.5 milligram per kilo, which is 500 mics. Full dose would be 1 milligram per kilo, 1,000 mics per kilo. Anything more than that, don't do it. We're already 100% cholinesterase inhibited. What's the point of giving more? Let's take a break. Okay. Back to page 63. That's neostigmine and edrophonium. Let's talk Sugammadex. Now, Sugammadex is, for that, turn to page 66. As you know, recently introduced a drug that is a unique reversible type agent. Sugammadex was specifically designed to what's called a cyclodextrin molecule. Dextrin meaning it's sugar, dextrose, and cyclo means in a circle form, and they can make the circle as big as they want depending on what they're trying to encapsulate. In this case, it was specifically made to encapsulate rocuronium. So it's called a select relaxant binding agent, SRBA. So it's a new class of drugs, SRBA, that works by binding the relaxant molecule, the rocuronium, in the plasma. It forms this complex where the cyclodextrin, you can see it in the little drawing here, and the drug's in the middle of it. Form the complex, and once this complex is formed, it can't be unformed, reversed. And this complex, the relaxant, Gamma-X complex gets peed out. So it's similar to what heparin and protamine do. The protamine attaches right to the heparin molecule itself, and the two are removed that way. Well, this is similar. The cyclodextrin encapsulates the relaxant and the molecule that is called renal elimination. Molecular chemists call this a condom, molecular condom. You make it so it encapsulates the drug and you get the picture. Now, let's take a look. Now, Gamma-X was tested in Europe, and I know you've had some lectures out elsewhere, but it was released in Europe and Japan and so on. And the FDA here wouldn't let it be marketed. And because there was a small reports in the clinical trials of patients with anaphylaxis. So that seems odd. It's a sugar molecule. Why would it cause anaphylaxis? But it does. And there was a small number, a handful of patients who, when they were reversed, had an anaphylactic reaction. So the FDA, of course, is ultra cautious. They wanted to see what happened in the other countries. The other countries got it. They used it for 4 or 5 years. Nothing seemed to be untoward. Then finally the FDA allowed it to be released at the beginning of last year, I think. And so now it's available and a very useful drug. So on page 67, select relaxin binding agents. And Gamma-X is the first SRBA to be introduced for reversal of neuromuscular blockade. The name Gamma-X is a contraction of sugar and gamma-cyclodextrin, and it forms a tight water-soluble complex at a 1-to-1 ratio with steroidal relaxants. So to only reverse the steroidal relaxants, it was specifically designed to reverse rocuronium. However, it will reverse vecuronium and pancuronium. They're also steroidal. It just is not as great an efficacy as it does to rocuronium. But you can use it to reverse vecuronium. Probably just need a higher dose. Reversal occurs independent of the depth of block, therefore even deep block can be reversed with the appropriate dose. The concentration of the free muscle relaxant falls rapidly and muscle strength is established. It's most effective reversing rocuronium and then vecuronium and pancuronium in that order. It does not affect the benzoyl isoquinone, so you can't reverse atracurium, cis-atracurium, or mivacurium, or succinylcholine. You can only reverse the steroidal relaxants. Now the package insert says, let's say you reverse somebody, they're in a recovery room, they're bleeding. In fact, Sandy was telling me she had a case like this Thursday. They did a lap chole, took the patient to PACU, and she was bleeding somewhere in the abdomen, had to take her back into surgery, right out of PACU, right back to the OR and stop the bleeding. And so if you gave Gamma-X to that patient, then they got to go back in and go back in the belly again, 30 minutes later for bleeding. What can you do? The answer is you can give a benzoyl isoquinone. So you can reverse the patient with cis-atracurium or Nimbex. That's not effective. It'd be hard to give rocuronium or vecuronium if you still had Gamma-X around. Okay. Used at appropriate doses, Gamma-X can reverse any depth of rock and vec within about 3 minutes. So here seems to be one answer to the issue of non-depolarizing relaxation or intubation. And well, just let me talk as often as I can. We've had for many years the issue of if you don't give sucks, you have to give a non-depolarizer because there's a contraindication to giving sucks for whatever reason. Maybe you just don't like it and you don't give it. And you're reversing you're intubating with a dose of rocuronium. Of course, you're giving 3 times E95. That's fine. It works fast enough to get you to intubate. What happens if it's a 30-minute case? You just gave 3 times the amount you need to get 95% paralysis. So this patient's not going to be able to be reversed for at least 90 minutes. Well, what happens if, worst case scenario, and they always make you learn about this in school, hopefully you're not going to see it in the real world, what happens if it's a patient where you try to do a rapid sequence, you're using rocuronium, and you can't intubate or can't ventilate? That's, of course, the big, monster in the sky for anesthesia folks. And there's always, well, you can't get them reversed because they're committed to 90 minutes worth of rocuronium. Well, now you can. And in fact, if you give the Sugammadex to that patient, 60 seconds after you gave them the rocuronium, you can reverse it. So the nice thing about Sugammadex is it works on anybody, independent of the degree of blockade around. If you give enough, you're going to get reversal. You're going to get reversal quickly. Now, is that still long enough for the patient to come back breathing and breathe okay? Who knows? It's always been kind of a question in the first place. I don't even know if sucks wears off fast enough. If you're not ventilating a patient and sucks wears off in 6 minutes, that's a long 6 minutes to me. But that's another story. Anyways, pharmacokinetics, page 67. Sugammadex is biologically inactive. It's just a sugar molecule, and it has a half-life of about 2 hours, and it's eliminated totally within 24 hours. No binding to plasma proteins, and it depends on renal elimination, so you have to be careful in people with renal disease. The complex that's formed with Sugammadex and the relaxant is peed out. If they have renal disease, you're not going to be able to pee it out, so it's going to last longer. So that's an issue. Now, the dosage range varies from 2 to 16 milligrams per kilo. 16 milligrams per kilo would be the can't intubate, can't ventilate situation. That's a hopefully never happen in your career situation. That's when you give such a massive dose of 16. Because you're looking for immediate, as fast as possible, reversal. The company recommends you dose according to the depth of blockade when you start to reverse. The dose for shallow or moderate block, say for example they have 2 responses to the twitch, is about 2 milligrams per kilo. Who hasn't given it yet? Everybody's given it, I hope. Right? No. Though some hospitals not that happen. Well, the normal dose is around 2 milligrams per kilo. That's for the average case, an average day, somebody who's got paralysis, maybe has 1 or 2 twitches back, and you go to reverse. Now, in a 70 kilo patient, that's 2 per kilo, that's 140 milligrams. That would be kind of your standard dose. Now, what many people do, because it comes in little vials of 200 milligrams in a vial, they just give the 200 milligrams. That's about what? A little less than 3 milligrams per kilo. So they cheat a little bit. Why throw it in the garbage? Just give it to the patient. It'll work. So the normal dose is about 2 per kilo, but since the vial has 200 milligrams in it, why don't you just give the vial and be done with it? Try to reverse, it's better if it lasts a little longer anyway. Right? If somebody has a deeper block, no responses, but the post-tetanic count is 1 to 2, meaning they're pretty blocked, there's no recovery, then you can bump up to 4 milligrams per kilo. The larger 16 milligram dose is reversing in the can't intubate, can't ventilate situation. Okay? And most of the time you're going to use 2, and somebody who's got no responses at all, the PTC is not showing anything significant, you know they're really deeply blocked, go ahead and give 4, and then can't intubate, can't ventilate situation, you go all the way up to 16. So again, I'm on page 68. Sugammadex is well tolerated. Most common adverse drug reactions include dry mouth, funny taste in the mouth, nausea, vomiting, coughing, the usual kind of stuff. Allergy is rare but possible. Remember, it was delayed release in the U.S. because of anaphylactic reactions, so it can happen. And Sugammadex-related allergic reactions include flushing, tachycardia, rash, all the classic things you expect from anaphylaxis. The other issue is that it can also bind contraceptives. Since women who take oral contraceptives, these are hormonal structured compounds, progesterone, estrogen, and whatever. And since they have the same similar structure to rocuronium, they can be bound and eliminated as well. So the company and all the literature says if you use Sugammadex on a woman who's taking birth control pills in childbearing age, you should caution or advise them, counsel them postoperatively that they should use a barrier contraceptive for approximately 30 days after surgery. So now that we're going to do pregnancy counseling, now that we get a new job, and the literature says that since there's oral contraceptive can be bound and removed from the body by Sugammadex, that you have to advise them to do some other protection, contraceptive protection, some barrier method that doesn't rely on the contraceptive. And that should for up to 30 days post-op. Now, if you look on the bottom of page 62, I put this in there for you. Bottom of page 62, recommended doses of Sugammadex. If you have reappearance of the second count of the train of 4, 2 milligrams per kilo. If you got post-satanic count 1 or 2, in other words, the patient's really deeply blocked, 4 milligrams per kilo. And if you need immediate reversal because of a can't intubate, can't ventilation situation, then it's 60 milligrams per kilo, 16 milligrams per kilo. Okay. Yes.
Is it fair to say that if the patient is on corticosteroid or if we're given a stress corticosteroid very often, that Sugammadex will render that effective?
It will lower the blood level of it. I wouldn't say it's ineffective, but it's less effective, yes. So if a patient's getting a steroid and they give Sugammadex, it definitely can lower the blood level of the steroid. Okay, any questions so far? Let's go to page 69. These are just some summary key points. The first set is from Dr. Miller's book, and so I looked at him and I kind of liked what he says, so it's a nice way to review. So let's go through some of these on page 69. The first bullet, there's 2 different populations of nicotinic receptors. N sub N, muscular, in the neuromuscular junction, and N sub N, which is at the ganglia of the nerves. Each of the presynaptic neuronal nicotinic receptor is also similar. Non-polarizing relaxants produce blockade by competing with acetylcholine for the postsynaptic subunit. In contrast, SUX produces prolonged depolarization, resulting in decreased sensitivity to the nicotinic receptor. Different forms of neuromuscular stimulation tests for blockade at different areas of the motor end plate. Depression of the response to single twitch is likely caused by blockade of the nicotinic postsynaptic receptors, whereas fade is due to the block of the presynaptic receptors. SUX is the only available depolarizing relaxant. It's characterized by rapid onset, ultra short duration, because of its rapid hydrolysis by cholinesterase. Available non-depolarizers can be classified according to the chemical class, steroidal versus benzoyl or according to onset and duration, is in long, intermediate, and short. And we've done both. the speed of onset is inversely proportional to the potency of a blockade. Oh, I didn't talk about this. Let me talk about this. It's not a big deal. I don't really care, but at least I can say it. The onset of a relaxant is inversely proportional to its potency. The more potent it is, the slower the onset. Now that seems odd, doesn't it? Here's why. If you got a drug that's very potent, you're only given a few milligrams of it. Since you're only given a few milligrams, it's going to take several minutes for those few milligrams to make it all the way around the body and get into all the muscles. It's just going to take longer to distribute because there's less molecules there being moved around the body. If you take a drug which has a low potency, like succinylcholine, how many milligrams of succinylcholine are you giving somebody? You're giving them 100 milligrams versus how many milligrams of Nimbex are you giving somebody? Oh, you're giving them 4 or 5 milligrams, right? Which one's going to work first? Well, it's going to be the succinylcholine, because even though the potency is different, you're given 100 milligrams. This is a lot of molecules you gave IV. And that's going to be easier for those 100 milligrams to get all the way down to your feet, all around the body, than it is for the 3 or 4 milligrams of Nimbex. Because even though it's more potent, it's just going to take longer to get everywhere because there's less molecules in the body. That makes sense? So, back to the statement. Let's see what it says. The speed of onset is inversely proportional to the potency. With the exception of atracurium, potency is predictive of the rate of onset. Its onset of effect is more rapid than either of these relaxants. So, rocuronium is faster onset than vecuronium or cis-atracurium because it's weaker. Alright, neuromuscular blockade develops faster, lasts a shorter time, is recovered more quickly in the centrally located receptors than in more peripherally located adductor policies. Remember, if you're looking for onset, I'm going to ask you this on the test. What are you going to look in? Facial muscles. If you're looking for offset, recovery, what are you going to look in? Hand muscles, adductor policies. Yes.
Sorry, you said rocuronium has a faster onset because it's weaker than vecuronium and vecuronium?
I believe so, yes. Yeah, see, rocuronium has a molar potency that's approximately 13% that of vecuronium and 9% that of cis-atracurium. So it's less potent. You have to give more molecules and it works faster. Okay. Our second last bullet. Long-acting relaxants undergo minimal or no metabolism. That's why they're long-acting. They're largely eliminated unchanged in the kidneys. Neuromuscular blockers of intermediate duration have more rapid clearance than long-actors. That's why we don't use the long-acting relaxants anymore. It takes too long to get rid of them. You can't reverse them. What's the point? Just use intermediates. Then finally, the last bullet. After administration of a non-depolarizer, it's essential to ensure adequate return to normal function. Residual paralysis decreases upper esophageal tone, coordination of esophageal musculature during swallowing, hypoxic ventilatory drive. Residual paralysis is a bad thing. It can cause increased morbidity and mortality. Okay, the next page. This is from Dr. Fleischer's textbook, Evidence-Based Practice. Choice of relaxant. Bullet number 1. If rapid onset is required, there's no contraindications, then give succinylcholine. It's the most predictable and rapid acting. It's the obvious choice. If myalgia is a concern, as in a muscular patient, a small defasciculating dose of an intermediate acting drug should be considered. Just give a small dose of whatever you're using for the case. If you're using rocuronium, give a little tiny dose of rocuronium first, then give them the sucks, then give them the rest of the rocuronium. Using Nimbex, use Nimbex, whatever. Just use whatever you use. Don't make it difficult. Bullet number 2, rocuronium at a high dose of 0.9 milligram per kilo, just rounded to 1, can achieve independent conditions in 60 seconds in most patients, comparing favorably to succinylcholine. Continuous following of the trend of neuromuscular block, try to keep the patient at 1 or 2 twitches out of 4. The risk of anaphylaxis is equivalent in most intermediate and long-acting relaxants. Therefore, it's not a consideration as to which drug you use. The incidence of anaphylaxis in anesthesia, the most common drug to cause anaphylaxis is what? What do you think? Group of drugs. All right. Antibiotics, 2, is another one. Latex, although latex has fallen off the charts because we don't use latex. Everybody's latex-free nowadays. But the antibiotics and the relaxants are the 2 drugs that are most commonly implicated in an anaphylactic reaction on the patient on the table. The most common relaxants to see anaphylaxis with are, I'm shocked, succinylcholine and rocuronium. Why would you think that is? Because that's what we give to everybody. Succinylcholine and rocuronium is about 90% of the market, so it's not surprising you see it most often with those. Residual blockade is the second last bullet, is a definite consideration and can have an output full dose reversal after initiation of some spontaneous reversal should be the common practice. So Gamma-X, finally, effectively reverses deep and prolonged blockade induced by ROC. Effective reversal dose is anywhere from 2 to 4 milligrams, and reversal will be accomplished anytime after the drug is given, even if it's immediately after the drug is given. Okay. And then page 71, I put a little blurb in here. This is also from Dr. Fleischer's book, talking about open eye injuries and the use of succinylcholine. And I've mentioned this several times, but I'll just say it again. If a patient comes for open eye injury, repair of a ruptured lobe, they're boarded for general anesthetic, most likely they are. Usually they're people who've been in some sort of a traumatic accident, either industrial or car accident, where they hit their face on the windshield, or Lord knows all the things that can happen, foreign body in the eye, etc. Then they're scheduled to have the repair of the ruptured lobe. The idea being that you don't want, first of all, the patient to cough or strain or anything during intubation, because that can cause the patient to rupture their eye. Coughing and straining raises intraocular pressure a lot. Secondly, you're not supposed to give any drugs that raise intraocular pressure for the obvious reason you don't want to excrete any of the eye juice and cause the patient blindness. So when you're doing a rapid sequence induction, because most often this is trauma, the patient's got a full stomach, and the question was, oh, do I give them sucks? Because the rapid sequence, so I'd like to use sucks, but sucks raises intraocular pressure. So the answer is, and this is, we can read through this, I won't do the whole thing. The answer is yes, give them sucks. Because what's most important is that you control the patient's airway. Right? The eye isn't going to matter. Reason being that you give propofol first. Say you've got an increase in intraocular pressure. Say it's running around 10. I'm just making up a number. You give them propofol and it goes down to 2. You give them sucks and it goes up to 8. Well, it's still lower than when you started. And it's not going to be an issue. What's most important is you did a rapid sequence, got a tube in, blew up the cuff, protected the patient's airway. That's most important. So the answer is, sucks raises intraocular pressure, but we still use it in cases with an increase in intraocular pressure because of the context of how we give it. You give an induction drug first, which blocks the increase in intraocular pressure. Let's read what Dr. Fleischer says, the last paragraph. When confronted with a patient, I'm on page 71. When confronted with a patient whose airway anatomy suggests potential difficulties, the anesthesiologist could consult with the ophthalmologist regarding likelihood of salvaging the eye. So first of all, talk to the eye doc and say, says eye, are you just taking it out, or are you trying to save it, or what's the situation with the patient? In selective instances outlined previously in which ocular injury is devastating, general anesthesia may be avoided if you can do topical or not. Usually you do general. Intubation may be safest management choice. Realizing substantial increases in IOP may be associated with gagging, retching, and coughing. They're not a big deal compared with losing the airway. So use sucks, control the patient's airway, everything else works out well. Okay, now on the bottom of page 71, I just stuck a couple of drugs there. I don't know why, but yeah, I know why I did it. The cert exam. NBCRNA talks about these drugs. Well, first of all, these are drugs given for Alzheimer's disease. And donazepam, Aricept, rivastigmine or Exelon, and galantamine, which is Razidine, are all used in patients with Alzheimer's disease. And what these drugs are is they're anticholinesterase agents, weak anticholinesterase drugs. They get into the brain, they have central passive blood-brain barrier, and they cause inhibition of cholinesterase in the brain, therefore raising acetylcholine levels in the brain, and that increases awareness, or has a stimulatory effect in the brain. Increasing acetylcholine in the brain makes you more awake, more aware. So these drugs are given secondary to some other medicines, most likely the patient may be on, but they're given to help, cognition, etc., in patients with Alzheimer's disease. Well, if you get a patient with Alzheimer's disease to come to surgery, which you do very frequently and almost a daily basis, operating room anyways, maybe not your patient, but when you get a patient with Alzheimer's that may be on one of these medications, the question is, of course, they're anticholinesterases. So you're giving our drugs to somebody who's on an anticholinesterase. So, the first thing, the books will tell you, is there going to be an interaction with succinylcholine? What do you think they would do to succinylcholine's behavior in the body? Make it last longer, right, exactly. Since Sux requires cholinesterase to be metabolized, and these are anticholinesterase drugs, Sux is going to last longer in these patients. Now, they wouldn't affect neostigmine or any of the other relaxants because they don't pass the blood-brain barrier. Either neostigmine doesn't, and the other relaxants don't. It's strictly peripheral. So they don't really affect the non-depolarizers or neostigmine if you're using that because that's below the neck. But they will prolong succinylcholine, supposedly. Now, my thing is, they only produce a mild reduction in cholinesterase in the brain. It's maybe 20%, 25%. Remember last week when we went through cholinesterase, in order to see any kind of clinical significant symptoms, you had to reduce cholinesterase by at least 50%, probably 60%. These only do a little mild, 20%. So you're not going to see any big difference in the patient's physiology. They're now walking around bradycardic, drooling, with diarrhea and having problems. Right? Yes, they are anticholinesterase, but they're mild. They're mostly CNS effective, and they do help a little bit with cognition. So will they make the sucks last longer? Maybe, a couple minutes, but there won't be anything that's significant. That's a potential drug interaction. Does that make sense? Okay, let's go back to page 7. And I also mentioned on page 7, on the first day back, that talk about the drug interactions on the bottom under miscellaneous. And I also therefore want to mention a drug called physostigmine. The trade name is anti-lyrium. And physostigmine is an anticholinesterase drug that is a tertiary amine. It passes the blood-brain barrier. So physostigmine is like neostigmine, only neostigmine doesn't have any CNS effects. It doesn't pass the blood-brain barrier. Physostigmine does. That's the whole reason for its administration. Passes into the brain, raises acetylcholine in the brain, and has an arousal or stimulatory wake-up type of effect. And physostigmine is occasionally used in the PACUs. In a patient who seems to be sleepy all the time, they can't wake them up. They want to see why. You can always give a little physostigmine and see if you can cause arousal in the patient, similar to what you do with flumazenil and benzodiazepine, that kind of thing. So if you hear about physostigmine, it's just an anticholinesterase, but it passes the blood-brain barrier. That's the big thing. Therefore, it has CNS effects. It can make you have a wake-up, arousal type of action. Right? Should you give it? No, it's stupid. Don't ever give it. What would you do that for? Just let the drugs wear out. If it's a benzodiazepine, give flumazenil. If there's another reason why they seem dry and they're not waking up, don't give them any more drugs. Just let them wake up. They will. Our drugs go away eventually. But if you work with someone that wants to give it, then hey, go for it. It's their license. Okay, and that's physostigmine. And now, phospholine iodide, the next one on page 7 down, I also want to mention, again, this is dumb. The certifying exam keeps asking this question. You can't let it go. They asked it when I went to school, and that was back before they had anything, lights. So, you can imagine they're still asking it. Phospholine iodide are anticholinesterase eye drops. Ecothiophyte is the trade name. They're used to treat glaucoma. In the old days, I'm talking about the 70s, 60s, 70s, 80s. The ecothiophyte eye drops are anticholinesterase. So in the eye, if you cause a parasympathomimimetic effect, make acetylcholine in the eye, then it opens up the canals and lets you drain fluid better, and it lowers intraocular pressure. So ecothiophyte was used as eye drops for many years. In the old days, you had to watch out for people on those eye drops because when you gave them sucks, the sucks would last longer because these are anticholinesterase. The problem is nobody uses them anymore. They haven't used them in 25 years. Everybody who has glaucoma now takes either a prostaglandin or a beta blocker. And they use ecothiophyte anymore. The cert exam, you just can't let it go. So I had to learn it, so you're going to learn it. Even though you never see a patient take it. Okay, that's that. Let's talk about the test, but before we do that, let's take a break. Okay, let's start it again. And what I want to do is go over what's going to be on the test next week. So let's start by going to page 7. Page 7. So exam next week will be the same as all my exams are. Um, multiple choice matching, the usual. It's 80 questions, all muscle relaxant related. The reading assignment will be chapter 12, which is everything we've been talking about. So let's get going. Page 8, how do you classify them? Either depolarizer or non-depolarizer, or ultra short, short, intermediate, long. Yes, but you know that already. It's not really something you have to study. All right, page 9, the neuromuscular junction. Just remember that acetylcholine is synthesized by the enzyme choline acetylase from choline and acetic acid. It's released and broken down by cholinesterase. Page 10, all the different neuromuscular blocking tests. Yes, know that. Page 10. What they are, what they mean, etc., etc. Okay, these top of page 11, these definitions, commonly used neuromuscular terminology. I gave you the definitions, and you got to match them with the description. In other words, onset time matches with time to drug administration to maximum effect, etc. So those 5 bullets are on the top of page 11. As far as onset and recovery, the next page, just remember that onset's best in the facial muscles, recovery is best measured in the eye muscles. I'm sorry, in the hand muscles. That's in the box on page 13. Page 17, the sequence for muscle sensitivity, neuromuscular blockade, what goes first, next, etc., and then how do they recover. Page 17, the top sequence, eyes, extremities, chest, abdominal muscles, diaphragms. Recovery is the opposite. Page 20. Yeah, I'm going to give you this. You're going to give me the thing on the bottom that I wrote in there. 4 responses, 3 responses, 2 responses, etc. Here's what I'll ask you. Patient has no twitches. How paralyzed are they? Patient has 1 twitch. How paralyzed are they? Patient has 2 twitches. How paralyzed are they? You get the point. Patient has 3 twitches. How paralyzed? 4 twitches, 3-to-4 ratio, less than 90%. How paralyzed are they? 4 twitches, 3-to-4 ratio, better than 90%. It's all written there in the bottom in bold. Okay, 22 sucks. You always have sustained contractions, so that all 4 twitches go out and come back together. The post-thin count, the lower the number, the more blocked the patient is. That's page 24. And the bottom of page 26. Characteristics of neuromuscular blockade. Yes, memorize this. I'm going to ask you this exact thing. What is a depolarizing phase 1 block? Sucks. What is a non-depolarizing phase 2 block? All the rest. Page 27. How many receptors are reversed when you can do these physical parameters? Just kind of have an idea of the number. For example, you can have a normal total volume rate, be 20% recovered, normal 3-to-4, 70%, or 30% recovered, et cetera, et cetera. Not be able to memorize the table, just kind of have an idea. All right. Page 32, metabolism, not much, it sucks. 2 stages, succinylcholine to succinylcholine, 2-succinic acid and choline. The enzyme is, of course, cholinesterase. Page 33, well actually 34, all the different anesthetic-related drugs in which hydrolytic enzymes metabolize them on the bottom of page 34. For example, Sux, Mivacurium, the ester local anesthetics, neostigmine and edifonium are all broken down with cholinesterase. And all the rest of these drugs, cis and atracurium, remifentanil, clozapine, esmolol, and non-specific esters. Okay, the atypical cholinesterase on page 35 and 36. On the top of page 36, diabetic inhibition test. What happens if you have a low number, a high number, normal activity, whatever? Know those 4 things. I'm going to ask you those 4 things. Here's the question I'll give you. You go to work. You have a patient that has prolonged apnea. You do a diabetic test. The diabetic number comes back. Pick a number. 80. The activity of the patient comes back in 10%. What do you diagnose? That kind of thing. And here's the 4 answers right here at the top of page 36. Okay, 38. Contraindications to Sux. Memorize them. 38, 39. And page 44. Yeah, learn this table. How are the relaxants eliminated from the body so you know which one not to give to what situational patient, etc. Page 44. I summarize it on page 45. Same thing. Page 46, histamine release. I'm going to ask you, what is the cardiac effects of the neuromuscular blockers? And you're going to answer those 1, 2, 3, 4 bullets on the bottom of page 46. A lot of stuff in there, isn't it? Page 50, drug interactions or physiologic interactions that can occur with the relaxants that prolong paralysis. Just kind of notice the bolded ones. Hypothermia on the left-hand column. On the right-hand column, the antibiotics, steroids, gas anesthetics, magnesium, lithium, and that. Okay, and then reversal, page 57. What are some of the clinical signs that say that the patient's reversed? Yes, know these. Open your eyes wide, cough, swallow, breathe, raise your head up a bit, squeeze my hands, bite down, the usual stuff. Okay, page 62 and 63, excuse me, was the issue of neostigmine, substitugamma dosing, and so on. So, where am I? Page 64. How does this neostigmine work? It acts as an alternative substrate. Now, page 65, I didn't talk about it yet. I talked about everything in the table, but let me talk about the table. What I did is I made this table up. It's from the chapter 12. And I wanted to have one page that summarizes everything you need to know about the relaxants as briefly as I could, one page. And here's my result. So I made this table up just so you can kind of remember the important or salient aspects of the drugs. For example, I'll just go through a few. Classification, ultra short acting would be SUX. Use the 80-95, the inhibiting dose, onset duration, how it's metabolized, whether it relies on kidneys, liver, does it have any autonomic effects or histamine release, and what's the cardiac action. I mean, you go across for every one of them. I kind of summarize it all in this table. If you know this table, you pretty much know it all. And that's about it. We got it. Any questions?
How about Dex so we can
Yeah, I'm going to just ask you, how's it classified, SRBA? What drug interaction can you get or issue? Is that it reverses contraceptives in childbearing age women who may be on contraceptives? Causes anaphylaxis. Usual dose is 2 milligrams per kilo for an average case, not too long. Trying to think of what else I asked you. That's it. Just the standard stuff, nothing fancy. Any other questions? Good. Cool. Let's go to page 72. Okay, our next topic is going to be local anesthetics, and I'll do a little intro to that, and maybe I'll quit a little bit earlier. Where you have a test after this. I will give you a break. But local anesthetics. So let's start, as always, I do, with the names. And these drugs that you've had from other people, and I know you've actually used some of them, both as nurses and as SRNAs, and done some blocks of them, etc. So, anyways, classification, local anesthetics, I'm on page 72. We break them down according to the chemical structure, that either being an ester or an amide structure. In the ester drugs, the only natural occurring, the first ever discovered local anesthetic was cocaine, and all the rest are synthetic, and that also includes the first synthetic local anesthetic. So they researched and tried to come up with a substitute for cocaine that wasn't as toxic. So they came up with procaine or novocaine, and that's the first man-made local anesthetic. It was back in the early 1900s, 1904, I think. Came up with procaine, and since then, if chloroprocaine, tetracaine, and benzocaine is topical, but it is considered an ester. So these are the ester-type local anesthetics: cocaine, procaine, chloroprocaine, and tetracaine. Then there's the amide local anesthetics. The prototype, the first one ever synthesized, was, of course, lidocaine. And lidocaine certainly is the most widely used local anesthetic in the world. Other amides are prilocaine, ropivacaine, bupivacaine, articaine, and metpivacaine. Those are the amides. Now, if somebody hasn't taught you this already, I will. Here's a dirty little secret on how to know which one is which, and that is the esters have one I, letter I, and the amides have two letter I's. So, for example, procaine is P-R-O-C-A-I, there's one I, right? N-E. So it has one I in the name. It's an ester. The amides, let's look at lidocaine. L-I, there's one. D-O-C-A-I, there's two. N-E. So that's two, it's an amide. So the amides have two, the esters have. Okay? Now this is going to be chapter 10 in the textbook, and I have all this great information. As far as miscellaneous drugs, when it's all over, I'll talk a little bit about Emla cream. I don't know if you had a chance to run in that yet in your travels, but it's a topical cream that we can use to produce local anesthesia. We'll talk about that. And then hyaluronidase, which is an additive. It's sometimes added to local anesthetics to help it spread. It's more commonly used as kind of a Botox treatment. It's very popular nowadays here in LA. $200 a syringe or whatever. Your face will never move again. Okay, let's go to page 73. I'm going to go on the camera and point. And the thing about local anesthetics, and I'll point this out right away, we know almost all the pharmacology of these. There's no mysteries left. These drugs have been around well over 100 years. They're all man-made. They know the chemistry in and out, backwards and forwards. They're very, very, now I think of all the drug classes we've talked about so far, these are the most well-known as far as their actions and what you'd expect and all that rest of it. So there's no big mystery to these. So let's go through just the beginning of this and then we'll call it a day. In order to be a local anesthetic drug, the drug has to have three chemical properties. There's three parts chemically in order for it to be a local anesthetic. The first thing it has to have is some lipophilic portion. Lipophilic means like lipid soluble, likes lipids. And that is usually a benzene ring. It's got to have a lipid soluble portion. You'll see why later on. It's got to have a water soluble portion, hydrophilic. I'm circling it here. That's the other side of the molecule. And that's almost always an amine molecule, this nitrogen here. It makes it water soluble. And then the lipid soluble side and the water soluble side are separated by what's called an intermediate chain, a certain number of carbons, hydrogens, and oxygens. And the intermediate chain can either be an ester link or an amide link. Those three things have to be present to make a local anesthetic in a laboratory. You got to make a lipid soluble side, you got to make a water soluble side, and you got to separate those two sides by an intermediate chain, either an ester or amide chain. Okay? Let me show you in the real world here. All right. This is lidocaine on top and procaine or novocaine on the bottom. So first of all, they have a lipid soluble side, this aromatic group here. That's the benzene molecule. That's the lipid soluble side. They have a water soluble side. That's the amine molecule here with its nitrogen. They both have similar things. And then it has to be separated by an intermediate chain. And in the lidocaine molecule, the intermediate chain is an amide link And in procaine or novocaine, it's an ester link. Why is this called an amide link? It's called an amide link because it has this C double bond O, the carbonyl here, C double bond O with an N next to it. That makes it an amide. C double bond O, see it here? N. That's an amide. If it's an ester, it has the bottom here, C double bond O with an O next to it. So the difference between an ester and an amide is an amide has a nitrogen in the intermediate chain, and an ester has an oxygen in the intermediate chain. But that makes a big difference in the body. Big difference. Here's what happens. I'll show you this later. I'll show you now, but I'll show you later. If you have an ester, see you've got an oxygen here. Look at the screen. And you got an oxygen here. They both are negative. These tend to repel each other in the real world when this is a drug folded into 3 dimensions. They repel each other. So that opens up this bond here. It makes it very easy to hydrolyze it. You break esters down by hydrolysis. Add water. You can add water to this real easy. So esters are really easy to metabolize. And they can be metabolized anywhere in the body. Because there's water everywhere. No problem finding that there. And the enzyme that breaks them down, cholinesterase. And that's everywhere. So it's easy to break the esters down and rapid, fast. Because it requires hydrolysis and it requires cholinesterase, both of which are everywhere. No big shakes. Now the amide, see that has this oxygen here with negative and the amine with a positive. That tends to close this bond off. They draw each other together. So you can't get water to go in here and break it open. So the amides are much more resistant to metabolism. In fact, if you want to metabolize an amide, you got to take it to the liver and metabolize it the usual way. Cytochrome oxidase enzymes, the usual drug metabolism enzymes, break them down, etc., etc. So the amides tend to be much longer acting because they require metabolism in the liver, not the tissues or the plasma or anywhere an ester can be. Make sense? The way they always teach us in drug courses is this. They say, well, procaine has good antiarrhythmic effects, just like lidocaine is an antiarrhythmic, right? You give it for PVCs. But you can give procaine too. The problem is, as soon as you give it, it gets metabolized. 60 seconds. Half-life of chloroprocaine, anyways, is 45 seconds. Procaine is probably 2 minutes. But it just goes away so fast it doesn't do any good. So what they did is they took procaine, made it an amide, put a nitrogen here, made it procainamide. Procainamide is pronestal. It's an antiarrhythmic drug. And it does the same thing, and this way it wouldn't be metabolized in the plasma. You could get a blood loss. That's just an example of how you can manipulate these molecules to make them last longer or shorter. Make sense? So, let's take a look at this last page here, 76. And here's all the structures. I couldn't care less whether you know this. I'm going to show them to you anyway. Couldn't be drug class without chemistry. This is procaine and chloroprocaine, tetracaine, cocaine, all the esters. And then these are the amides below. And you can see in the esters they have a C-double-bond-O link. And then the amides, the C-double-bond-O-N link. They're all amides. And that's the difference between the esters and the amides. Chemically. Now, it makes a difference to know that because if you look on page 75 in the top, I made this table. Whether a drug is an ester or an amide makes a difference clinically. Here's the difference. Okay, number one, esters are metabolized by cholinesterase via hydrolysis. It occurs throughout the body and it's rapid. If I want to give somebody a block, and I use procaine, it's going to be metabolized right where I put it in the block. I better use an amide so that it doesn't get metabolized. Esters are metabolized everywhere. Plasma, tissue, doesn't matter. You got water, you got cholinesterase, you can metabolize, right? On the other side, amides, I'm reading on the table on the top of page 75, the amides are metabolized in the liver by the CYP enzymes, so that you can get a significant blood level of an amide, not an ester. Does that make sense? Okay, number two, allergy to local anesthetics. So let me stop and talk off on the side for a second. When do most people get a local anesthetic? When they go to the dentist. When most people go to the dentist, they get injected with some local, work on your teeth, and everybody hates it. They hate going to the dentist. And they get injected. And the dentist is injecting you for two reasons. Number one, he or she wants to get numb the tissue if they're going to work on it. Number two, they always have epinephrine in there because they want to cause vasoconstriction because the gums are so vascular. They're going to have a lot of bleeding if they don't put some vasopressor in there. So they give you lidocaine with epinephrine, or in fact they use articaine or one of the other ones. Put epinephrine in there. Well, you're already nervous. You're the dentist. You don't like it. Their fingers are in your mouth. They're injecting epinephrine in your gums, which is very vascular. You absorb it, and your heart starts pounding from the epi for a few minutes. You feel warm and tingly, and what do people say? I had a reaction to the local anesthetic. So they say, well, I'm allergic to Novocaine. Oh, no, you're not. Because, first of all, I doubt very much there's a modern dentist in the world that's using Novocaine. They don't use it anymore. Only uses lidocaine. And number two, most likely it was that you were just nervous as a dentist and you felt the epinephrine being absorbed, and that's what gave you the reaction. So it's very difficult, in other words, to tell by history. If somebody tells you they're allergic to local anesthetic, or I'm allergic to Novocaine, which is what most lay people call the local anesthetics in the dentist's office, still, even though we don't use Novocaine anymore, then it's hard to tell true allergy. So here's the way it works. Take a look at the middle panel in my table on the top of page 75. Although local anesthetic allergy is uncommon, and it is, it's very rare to be allergic to a local anesthetic, the esters have a higher allergy potential than the amides. If somebody's allergic to a local anesthetic, they're almost always allergic to an ester. And the reason is, the esters are derived or synthesized from a compound called PABA, para-aminobenzoic acid. PABA is a constituent in a lot of cosmetics, sunscreens, and topical ointments, and stuff like that. So there's a better chance that a human being has been exposed to PABA somewhere in their cosmetics or in their lotion they're putting on for sunburn, or whatever they're taking, to bad tooth, they're putting some Ambisol on their gums or whatever, and therefore develop an allergy to the PABA, and then when they got a local anesthetic ester, they had an allergic reaction. They're almost never allergic to an amide. In fact, I actually was just reading a book a couple weeks ago, and they said there's never been a demonstrated true allergy reported to lidocaine, ever. If you think about that. Lidocaine came out in the 40s. And it is easily one of the most widely used drugs in the world. We use lidocaine for everything. In emergency rooms, in ICUs, everywhere in the hospital, anesthesia, of course. We do everything but clean the machine with lidocaine. And they never reported an allergy, a really true allergy to lidocaine. So that's, in other words, the allergies to the amides are almost non-existent. That's my point. So, here's the way it works. If a patient's allergic to an ester, they're allergic to all the esters. You can't say they're allergic to procaine, then you can't give them tetracaine. They're allergic to all the esters. But they're not allergic to the amides. So there's no cross-allergy between the esters and the amides. If the patient, for whatever reason, and there are some examples of a patient being allergic to an amide, like bupivacaine, you can get a scratch tested. Go to an allergist and get tested for this. If the patient is allergic to an amide, they're not allergic to all the amides, they're just allergic to that amide. And they're not cross-allergy allergic to the esters. All right, I'll say it again. If you're allergic to a local anesthetic, 99.9% of the time it's going to be to an ester. And if you're allergic to an ester, one ester, you're allergic to all the esters. Can't give any of them. But you're not allergic to the amides. Conversely, if you're allergic to an amide local anesthetic, you're just allergic to that amide. You're not allergic to all the amides, and there's no cross-allergy over to the ester types. And that's the way it works. And you can't get tested. Make sense? Now, lastly in my table, the ester drugs tend to be shorter acting due to ready metabolism. Tetracaine is the longest acting ester. The amides are longer acting because they are more lipophilic, protein bound, and require transport to the liver to be metabolized. All right, so I'll finish up by saying this one last thing. I'll even close my book, so I promise I'll finish. I won't see something. Oh, let me say this. Let me finish up by saying this. When we talk about the local anesthetics, and we'll do it again next time we meet in 2 weeks. Pick it up here. Remember, these drugs have the opposite kinetics of any other drug we talk about. And this is what I mean. You already know this. This is common sense. If you give a local to somebody, you're trying to get the drug to stay locally where you put it. As long as let's say I'm going to block somebody's wrist, because I'm going to put an A line in. All right, I'll pick a simple example. So I give a couple mLs of lidocaine in the wrist, and I want the patient to be blocked. So as long as the lidocaine stays in the wrist, the patient's going to be blocked. As long as the concentration of the local anesthetic is higher outside the nerve than it is in, it'll move into the nerve and block it. Then blood flows through there, half an hour, 45 minutes. Blood flow picks up the lidocaine, takes it away. And so absorption of a local anesthetic is what causes its offset. See what I mean? Usually when you give a drug, you go in and give somebody an IM shot. Oh, nurse, I need a shot of something. You go in and give them a shot in the butt. IM. It doesn't start to work until it's absorbed into the bloodstream, right? Carried off to the receptor. So absorption causes the onset of all drugs, except local anesthetics. They're backwards. When you absorb a local anesthetic from the place that you stuck it with a needle, that means that where it's wearing off. It's not starting to work, it's finishing working. You got to keep it local in order for it to work. Does that make sense? So kinetics are backwards. Absorption is offset, not onset. All right, see you in a couple weeks. I quit. Good luck on your test.